This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I'm Mariana Parks, physical therapist and your host, and today I interview Dr. Vikas Agarwal to discuss the resolution of non-cardiac chest pain through exercise. We talked about how he integrates the mechanical concepts of the McKenzie Method into his primary care practice, the concepts of mechanical pain and sclerotomal pain in medicine, how cases of peripheral polyneuropathy, sinus issues, oropharyngeal dysphagia, chest pain, abdominal pain, pelvic pain, and dysfunction can have mechanical causes and respond to exercises, and the paper he just published in the Annals of Internal Medicine, the resolution of non-cardiac chest pain with corrective exercises for neck and upper thoracic spine. Dr. Vikas is an internal medicine physician and also certified EMDT. If you find this conversation valuable, I encourage you to subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share with other clinicians who could benefit from this conversation. Thank you for tuning in, and we hope you enjoyed the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Hi, Dr. Agarwal. Welcome to PT Pro Talk. How are you today?
I'm doing good, Mariana. Nice to see you.
Yes, it's good to finally get together to do this podcast.
Yeah.
So let's start just talking a little bit about yourself for the ones that don't know you yet.
I am based in Kansas City, Missouri. I'm an internal medicine physician, practicing here now for almost 23 years. I got certified in mechanical diagnosis and therapy way back, I think almost 8 years back. But I've been doing this modality, trying to integrate this modality into the practice of medicine for almost 12, 13 years. Integration of MDT into the practice of medicine has truly transformed my practice and opened my world in understanding the human body in a very complete way, which I think I was missing before.
And that's awesome. And that's what I wanted to ask you next. So how do you integrate on your practice MDT, and how did that change the way that you practice medicine?
Right. So initially, Mariana, it was more of, it was localized to musculoskeletal medicine and the pain complaints. So how should I say it? Prior to MDT, if a patient comes to me with any pain complaint, whether it is back pain or knee pain or whatnot, any physician, I think, in the US has one of the four options to do. Either you give a pain pill or you do a test, either an imaging study or a blood test, or you do a small procedure like an injection, or you can refer the patient somewhere else to neurosurgery or to chiropractic or to PMR or whatnot. However, once I got trained into MDT and I started implementing that in my practice myself, hands-on, all those four parameters actually reduced dramatically. And one of the amazing things was that I could provide instant relief in many times right on the patient visit, which was not available to me prior to that. Because even if you're giving a pain pill, whatever, what will happen. But here, you could see the influence right away in front of my eyes during that visit itself. So that helped me reduce the polypharmacy, of course, the pain medicines, but it really consolidated and simplified the medical chart of my patients, honestly. So
yeah, and that's probably so rewarding to be able to help your patients right then and there when you're
right,
seeing
you
them.
can see the influence. Yes,
Yes, that's
not always easy though, but yeah.
yeah. And so I'm just curious to ask about like your other colleagues. So like you just practicing in a very different way. Did that get like other colleagues' attentions? Were people interested on your work that was different, or how did that change at all the work of people around you, or and how was the repercussion of your new way of treating?
Very good question. So it's very fascinating when I stumbled upon McKenzie and I discovered it and I saw how effective it was. Like I was just so excited, and I right away took all the courses and exam to get certified. And I thought that other physicians, will jump on it because it is so powerful, so empowering to yourself and to your patients. But interestingly, I didn't see the traction, to be very honest. And part of the reason, which I feel, is because the science and the modality is so different than how we are trained in the medical world.
Mm-hmm.
I'm saying mainstream allopathic medicine, that bringing that into the fold, it really it is an unnerving situation, and it was very difficult for me also initially to embrace the concepts and how things are, because it challenged and kind of disproved what I believed in and what I was trained in, and it wasn't an easy experience or a smooth ride. However, the patients, they taught me, and the patients were forcing me to adopt this modality, because again and again, that was where I was finding the answer. So yes, in my group, people are aware, and they refer some of their difficult patients to me. Of course, I get referral from all other specialists from far off places too, but honestly, no, the intake or the uptake, whatever you may want to call it, has not been that widespread, surprisingly.
And it's so interesting that even with like such good results, how did that not get more people's attention? I'm sure the patients loved it because they go to the doctor and they leave with more answers or instant relief. But like, I just found that so interesting that how it didn't get other physicians' attentions, like knowing that you have those type of results.
Right. So you may be surprised or maybe shocked to hear this, but and I know you are certified in MDT, and that is your world, mechanical diagnosis and therapy. But the mechanical pain and the mechanical concepts doesn't exist in the practice of medicine. I know it is
Yeah.
shocking. If you go back to the basic sciences, we are, and this is not a alternative treatment or a holistic medicine, which some people want to call it. I believe MDT is truly scientific. It's so reproducible. It is reliable. There's validity. That's why it is in 33 different countries all across the world, in different languages, different settings. And if we go back to the basics, we have only three sensors. One is free pain endings for inflammatory pain. Then we have uh, we have thermal sensors for heat and cold. And the third is mechanical sensors. So it is as basic and as rock solid as it could be. However, if you go to the practice of medicine, for example, we have a book which is considered the Bible of internal medicine, Harrison's Principles of Internal Medicine. And if you will type, or if you will, now that it is online, so you can clearly see, if you will type mechanical pain, there will be zero answer. It doesn't exist. And so when something is so foreign, so blind, or so dark in terms of awareness, I think that makes it a challenge, you know.
Yeah, that is
And
crazy.
yeah, it is. It is. And I've thought about it, why it is still an issue. And one of the reason which I think I've kind of come to terms with is there is really no anti-mechanical pain pill. There cannot be, because anti-mechanical, you require a corrective force to correct the
Mhm.
abnormal mechanics, right? So there
Yes.
cannot be a pill. And if there is a pill, they can design a pill to block the mechanical receptors, like, but still that will lead to so widespread effects on the body. It won't be successful. Now
Mhm.
you may be aware of. There was a Nobel Prize which was awarded to the two scientists from California who finally they were awarded for discovering those mechanical sensors for mechanical pain. So it is as basic and is as scientific as it could be. Now we even have a Nobel Prize winner for discovering those mechanical sensors, and he highlighted the mechanical pain. Still, the mainstream medicine is totally unaware of it. Part of it is because there is not a pill, there's not a test, there's not a blood test or any imaging test which can diagnose a mechanical pain. And there is no, in their world, they do not have, okay, once you know mechanical pain, they do not know what to do with it. So there is no treatment.
Yeah.
So when all the three aspects are not there, why would they acknowledge that, even though it is as basic that now we even have Nobel Prize Committee acknowledge that? And so part of the reason is that, in my opinion.
Yeah, I think it's surprising to hear that as a physical therapist, because we we live and breathe movement. So it's
Mhm.
the first thing that it comes to our mind. So it is very surprising. And when you say pill, we play that the pill is the movement. So you take your pill, you're gonna do your exercise. That's your pill.
Mhm.
So it's just
Yeah, and
interesting.
we majority of the pains are mechanical pain, but we treat with anti-inflammatory pain pills
Hmm.
or opioids, which are not really targeting the cause as
Hmm.
to what is generating the pain. So
Yeah,
there
yeah.
we have it.
And so let's talk about, like, what are the common cases that you see that they go look for you, and you end up helping them with like a mechanical approach.
So the case is actually, it is just part and parcel of everyday life. It is so. Of course, there is traditionally, MDT is for back pain, neck pain, and joint pains, and headaches and dizziness. However, over the years, as I was doing these interventions, I started seeing influence on other modalities, other symptom presentation, and the symptom presentation are and that is what actually totally shocked me and made it so interesting, that some of these labels which we were stuck with, they are not hard and fast labels. For example, diabetic neuropathy, you know so there's no treatment. Once you have tingling and numbness in a diabetic, there's there's an EMG, you will do a EMG to prove it, whatnot, and then there is carbapenem or other kinds of duloxetine or other kinds of pills to treat that. There's nothing to cure it. And I cannot share that with you, Mariana, how many of so-called peripheral polyneuropathy, and even for 10-15 years, they were completely or almost completely resolved just by doing the lumbar exercises, by doing the McKenzie intervention. And so these labels are also not hard and fast rule. And part of the reason I feel is, when you start moving the lumbar spine in a corrective way, these neurons, the exoplasmic flow in the neurons in the cells, it starts reaching the periphery, which is the toe, the distal part of the toe, and it gets nourished and the symptoms disappear. So So if we are talking about how much MDT gets influences, and again, I want to be careful in sharing all this because it may look like quackery. Oh, you are treating no, that is not the case. There are several real neuropathy patients which will not be cured or fixed by MDT. There is real nerve damage that is done. Then those are the medical causes. But what I'm sharing is there are many of them which are reversible. And unless you do a MDT intervention, you will not know which is reversible and which is not. So the medical terms like neuropathy, nobody treats in MDT world. I know the physical therapist will not treat neuropathy because nobody will refer them a neuropathy patient. So slowly over, so many things happened. There were so many other symptoms like sinuses. A lot of sinuses actually are mechanical, believe it or not. They may call it allergies or they may call it sinus congestion or stuffiness, but it is because of the trigeminal-cervical nuclear complex, the same thing which is the genesis of your cervicogenic headache. Actually, the trigeminal nerve, which is supplying our sinuses, that gets irritated and that reacts to every change in humidity, pressure, perfume, pollen, and whatnot. And CPAP, believe it or not, like when this pressure, the CPAP we use for obstructive sleep apnea, OSA,
Yeah. Yeah.
a lot of those people have hard time using that because it is stuffy, like they get stuffy in the sinuses. But all that is more of a nerve sensitivity. It is more of a nerve irritation. And that gets reduced significantly if you do the corrective neck movements. So,
Mhm.
so it has been, I have very, very few people who take cetirizine or nasal spray, very few. Over the years, they all have been um, doing the retractions and they are fine, especially some of these older people, who cannot wear the CPAP.
Mhm.
And this symptom complex, may not get the glamour or the status of, like, for example, cancer or a heart attack or a stroke. But I cannot share with you how relevant and important this symptom presentation is because they feel horrible day in and day out. And
Mhm.
if you clear their head, it just transforms their life big time.
And like, how did you decide to start testing to see if there was any relation? I was just curious to ask.
So that is the thing. As a internal medicine, as a primary care physician, when you are uh, giving the neck movement, and then the patient will come and say, "Oh, by the way, it has helped me here also." And so
Oh.
that's how you start doing the correlation, and then you start playing around with, okay, whether repeated movements is going to work or whether sustained movement is going to work, or if this is not working, if we need to do it in a different force to get them going. So it is
Mhm.
not one answer for everyone, but then you get more insightful, okay, how we are going to move on in
Mhm.
correcting that.
Mhm.
And a lot of we do plan to do some work in oropharyngeal dysphagia. That also actually is related to the neck. I'm not talking just from the physical part of the neck. In those old patients where you see there is a physical part of cervicothoracic kyphosis which leads to aspiration or difficulty swallowing. I'm talking about upper pharyngeal area. Apart from that, I think there is a nerve connection similar to trigeminal cervical complex. All these cranial nerves actually interact with cervical nerves. And I think there is a big interplay with the cervix C spine and some of these cranial nerves. And that's why we see so much of influence on different clinical presentations, which I do it day in and day out. Of course, I make sure they do not have cancer or they do not have a true medical problem because I'll get in trouble if I miss
Yeah.
that. I'll do all the tests, but uh, I don't know how to share with you. But it's short of just amazing how much you can make an impact just by simplicity.
Yeah. And so powerful just to know how to first, of course, do your test, exclude potential causes of
Mm-hmm.
something more serious, and
Yep.
then knowing how to treat
That is the
them.
golden rule. You cannot
Yes.
afford to miss a medical cause. That is the golden rule.
Yeah.
So I want to highlight that MDT is not in, I'm not at all claiming, and I'm experienced, like I'm practicing that, oh, this will fix this, or this is for neuropathy. It is not that. It is
Mhm.
only certain people where we see the response, because there are
Mhm.
different causes. All I'm saying
Mhm.
is if it is a mechanical cause causing that symptom presentation coming from the spine,
Mhm.
yes, that can help. In
Mhm.
that particular scenario, it can help. And so similarly, I will share with you a lot of, and you know all that, tennis elbow or golfer's elbow or carpal tunnel, how much of it is C-spine related,
Yeah.
and it is
Yeah.
such a common phenomena. But just to share on that front, I may share that a lot of Raynaud's phenomena, where you get vasospasm and cold and all
Mhm.
that also actually gets influenced by corrective neck exercise. It may not completely eliminate that, but it does influence
Mhm.
it. And if you really think about it, at the end of the day, it is the autonomic nerves and everything, they are all going in, and I think that's how possibly it gets influenced.
That is crazy. I'm just so curious to ask you all these different cases. So you said the sinus, diabetic, neuropathies.
Any kind of neuropathy, the tingling sensation and
Yeah.
numbness. A lot of
Yeah.
people, they come with, and the reason I'm so passionate about, for example, neuropathy, is that is huge, Mariana. The reason it is huge is it is not just the uh, symptom presentation which is affecting them.
Mm-hmm.
Actually, it is a much bigger issue. The bigger issue is actually the balance. And if their balance is off, they stop walking that much, and they are at high risk of falls, which leads to all the fractures and all that. So there's a downstream
Mm-hmm.
functional and morbidity and mortality, which is linked to a very simple thing. And if you
Mm-hmm.
really think about it, if you are giving gabapentin, which is practically the commonest drug which is given for that symptom presentation,
Mm-hmm.
that just numbs the positive symptoms. It doesn't do anything in terms of improving the balance or the functionality, you know.
Mm-hmm.
So it
Yeah.
actually, and it has side effects, both central, and of course, people get edema in their feet and they are more goofy or whatnot. But
Mm-hmm.
regardless, if you can fix the cause, the rewards are, they multiply over time on
Yeah.
so many different aspects.
I'm just thinking here how many people could be helped if you had more physicians trained like you. That would be
That's
like
what
a
I am
huge.
trying to help the world know, that this is I've been doing it now for so long. This is much beyond initial placebo effect or just some cuckoo-ness or whatnot people may call it. It is there is
Yeah.
a real uh, scientific response which I see. Now, of
Mm-hmm.
course, we have to do more studies and all that stuff. I've been seeing chest pain, abdominal pain, pelvic pain, and so many other presentations, again, which are treated by MDT.
Mm-hmm.
But it is difficult. Finally, we have the paper published in a medical journal of,
Congratulations on that. That's huge. Very exciting.
yeah, it Mariana, too. Even this paper, actually, it took almost 3 years to get it to see the light of the day. It wasn't easy. And first time I tried to publish was 2016. Those were also series of abdominal pain patients. But of course, I got rejection after rejection. The best response was, what I got was from Mayo Clinic proceedings, that, okay, we can accept you as a letter to the editor. But at that time I said no, like this is so big, and I felt, so that's how I got so frustrated. I said, and again, it boils down to, when you are submitting to a medical journal, as I shared with you, there is no concept of mechanical pain. And there's no concept of actually sclerotomal or somatic referred pain. That is another big deal, because physicians do not acknowledge, we are not trained to understand somatic referred or sclerotomal pain. And so, which forms the basis of this chest pain, abdominal pain coming from the spine. We are aware of radicular pain, we are aware of local chest wall pain or local abdominal wall pain. But in terms of acknowledging sclerotomal pain, no, I'm sorry, it doesn't exist in our world.
It is crazy. And we were discussing like your paper prior to our conversation, and we were talking about the difference. So would you just explain to our audience what is the difference between the somatic referred pain and the dermatomal pain?
Right. So, and again, I'm just sharing. By and large, in the MD world, we are very well aware of dermatomes. Everyone knows the map, and you have seen those maps. They are very clear cut defined. However, the sclerotomal pain, so dermatomal pain is ectoderm based. Like, if I can simplify it a little bit, as embryologically, as the embryo is forming, we form from three layers: ectoderm, mesoderm, and endoderm. Ectoderm forms the skin, mesoderm forms all the connective tissue, skeletal, muscle, bone, and endoderm forms the internal organs. I'm trying to talk in a simplified way. Of course, there are some variabilities there. And as the nervous system is developing, I think the nervous system follows the same nerve pattern wherever the organ is growing. And so when we are talking about ectoderm, that is much more well defined. It is sharp, burning, localized. It is reproducible. That is the kind of pain you get in, for example, shingles or in sciatica, where there is a nerve root involvement. Somatic referred or sclerotomal pain is actually underneath the skin, in the in the connective tissue, in the muscles, in the bones, but it is vague. It is diffuse, it is achy, it is not well defined, and the areas overlap. And but it is again linked to the same spinal segment. And so, if anywhere in that particular sclerotome, which comes from, for example, if you are talking about chest pain and going all the way to that particular level of the spinal cord, any irritation in any part of that particular sclerotome can project pain there or elsewhere. And so this forms the basis of referred pain. So if there is a mechanical issue in that particular sclerotome in the neck area, that can project pain here. How we are going to come to know? We do not have any test or capability right now. However, if you do the corrective movements, you see a very quick response. As you know, with McKenzie, it is not a traditional physical therapy where they are targeting the muscles or trying to build up muscles and whatnot. I view MDT more as a corrective of the joints. That is where the derangement and main issue is. And the nerves. I think we use the word mechanical, but by correcting the mechanics, we are influencing the joint position and the nerves, which are supplying that area. So.
And talking about chest pain, I know that you published 3 study cases, right, on that paper that you just published. Would you just briefly talk about those cases? Give us a few examples on
Right.
how did you assess and treat and the results?
Right. So these, I was mentioning, I couldn't get the cases published earlier last decade because they were all my patients. And so, people probably assumed, or whatever the reasons were. So this time, actually, we elevated the game. So these were not my patients. These were actually referred from a tertiary level academic center. And they were referred after they have done whatever they could do in terms of cardiac workup and GI workup. And you can see in the paper, all sorts of GI gastroenterology tests were done to decipher the cause of the ongoing chest pain in these people. And once they had exhausted and they were still not any better, that's when they were referred. And we did the MDT intervention, and then they went back. And that's how we increase the credibility of our work, that this is not just one center cases. These are coming from far off places, and they are being resolved by doing the McKenzie intervention. So they all were from referred by gastroenterology clinic, and they, of course, they all were ruled out heart first. When we talk about chest, everyone first wants to rule out heart, but many of them, they had gone through a lot for a long period of time. One of them had a cholecystectomy, no better. They had all sorts of tests. They were on all sorts of proton pump inhibitors, muscle relaxants, anxiety medicines, and whatnot. Diltiazem too, because the theory was, okay, it could be a esophageal spasm which is causing all this ongoing pain, when it wasn't. And so we stopped all the pills, and the patient beautifully responded to the MDT intervention because the cause was there. And not only that, their anxiety and depression precipitously dropped within a month. So this notion of psychosomatic pain or anxiety causing the pain and whatnot, I think you really cannot go there unless you have ruled out a mechanical cause.
It's probably the other way around. They are anxious because they don't know the cause of their pain, and not the anxiety that's causing the pain.
Yes, it goes. Actually, I feel having an unknown, or even if I'm a patient and if I see a doctor, and if they are not able to decipher what is wrong with me, and all of these people, they blamed themselves. They felt there's something wrong with themselves, that they are hurting, they are crazy, when honestly that is not the case.
Yeah.
And because after seeing so many physician after physicians, and after so many tests, when nothing is found, and they hear again and again that everything is normal, so they start doubting themselves.
Yeah.
So,
yeah, uncertainty just brings all these doubts. Anxiety. Yeah. And so what was the intervention we were talking about? On the paper has the pictures showing really nicely the intervention we're going to share with our audience. But would you just briefly talk about what were the exercises that the patients did?
Right. So all three of the cases in the study, they were a combination of they all responded to the extension based principle, but they were combination of retraction extension, or seated thoracic extension, along with posture correction. So in those cases, actually, I also did in two of those cases, I did a clinician procedure of cervical traction, retraction, and extension. One patient didn't require that because she responded to simple retraction and retraction extension. But yeah, those were the movements as outlined in the paper.
And did you notice any difference between repetitive movements and sustained positions on those cases?
Not in these cases. So they all were repeated movements responders.
Okay.
So sustained, I see more with sinuses and headaches in the neck area. Not by and large in other areas, it is usually a repeated movement response.
So like, do you play with different positions on the sustained retraction, supine, prom? Like, do you see difference on those cases?
Right. So as you know, doing a sustained retraction by the patient or even by a clinician can do only a few times, is tough. It's difficult. However, if you are in the prone position, you can do a sustained retraction somewhat easily. So I'm not sure if it is just the duration or the ability of doing the retraction, or if it is a force alternative, which is the responder. But at the end of the day, as you know, we just play around with things to wherever we can get a response.
Very interesting. And then on those cases that you treat the chest pain, so they perform the movements. Did you see the difference right away in the office, or they performed the exercise and then came back reporting that they were better?
No, I do the movements myself. They do it in the clinic,
Mm-hmm.
hands on. And usually that's how I'm assessing whether there is a response or not. And majority of the times we do see some influence right away.
Mm-hmm. Mm-hmm.
Um, and the key is the education, because it is not easy to sell a neck exercise or a spine exercise for somebody coming with chest pain or abdominal pain. Trust me.
Mm-hmm.
And so they need to hear that. They need to hear the rationale. Very commonly, I show them a sclerotomal referred pain pattern that
Mm-hmm.
helps me engaging them. And as I was sharing with you, after seeing so many rejections in 2016, when nobody was ready to publish my case series, at that time, I said, okay, enough is enough. They don't want to blame me, and that's fine. Let the patients speak for themselves. And that's what led to the birth of YouTube channel.
Mm-hmm.
And so, but I didn't realize at that time, I was so frustrated. I said, okay, let the patients speak for themselves, and hopefully people will see what they are trying to say. But very interesting thing happened out of those cases, actually. And I didn't realize at that time. But as we moved on, actually, those cases helped me engage my future patients much more easier,
Mm-hmm.
because the clinical presentation, what they were having and which they are coming with, that helped me get a buy-in. And
Mm-hmm.
so, you know how everything works out. You do not know where the blessings are, and
Yeah.
I think it was actually a good thing that my paper didn't get published. Maybe at that time, because that led to I got more stronger and I was able to engage my practice much more easier. It became easier and easier to engage them into, and so that led me to publish more videos and record them. And just to share with you these videos, for somebody to come on the social media or to YouTube, they need to be pretty convicted, but they are ready to share because they feel so passionate about it,
Yeah.
that other people need to see this. And there is a simple answer, like it doesn't cost any money. It doesn't need to, you don't need to buy anything. You just need to do some corrective movements yourself. And uh, and the other thing, yeah, other challenge also is, apart from helping them engage, the simplicity, because they've been hurting for 10 years. They've gone through all the tests, they've taken all the pills, they haven't gotten better. And when you
Mm-hmm.
say to them, they look at it, yeah, I've heard that before. Yeah, so many people have told me that before. And
Yeah.
so, so it's a interesting journey. Yeah.
I just think it was interesting that you were saying that was hard to get sometimes the patients buy in. Uh, if they have chest pain, that could be from the spine. And I was just thinking, if for the doctor is hard, for the PTs is much harder, because usually the doctor is the first point of contact, the ones that are diagnosing them. So it is a challenge. It was just funny to hear that it's a challenge for you too. So it was just.
Right, right. Fortunately, and that's why I feel so lucky. Fortunately, yeah, I have so much lead advantage in at least not corrupting their mind.
Mm-hmm.
They are not hearing two different viewpoints. They are hearing, by and large, if they are coming to me from somewhere else, of course, you do your due diligence in helping them understand the new concept and all that. But one of the things which has helped me over the years is, um, that they are not corrupted. They are not hearing different
Mm-hmm.
viewpoints from different doctors, and that helps
Mm-hmm.
me engaging them
Yeah.
into that.
Yeah.
Actually, I show them, I've got all the patient education materials. I use Google to show some of the diagrams. But one of the things I use, and again, patient education is so important. We were talking about somatic referred pain and sclerotomal pain. It may sound like foreign what I'm talking about in reference to chest and abdominal pain, but Mariana, you deal with it every day. The buttock pain, what you are having, or the thigh pain, which is coming from the right lower back, that is not a radicular pain. That is a sclerotomal referred pain coming from the lumbar spine. So people assume, okay, that is fine because it is in the buttock area, which is close to the spine, or which is the extremity, or the neck pain or the shoulder pain, which comes from the C spine. That is a sclerotomal referred pain. That is a somatic referred pain. It is not a nerve impingement which is causing a radiculopathy. It is so common. So everyone thinks that is fine. But when the same human body, we have the same human body, no matter how much specialization or compartment you can make, when the same thing actually projects over the trunk, why would it not project to the trunk? Tell me. It goes to the back. Why would it not come to the chest and abdomen? Just because there was nobody to look into that. And it just shocks me that this appreciation or understanding this was the first paper to show the documentation in the medical literature that the chest pain could be coming from the neck pain. Of course, we will have more studies where it will show abdominal pain, pelvic pain, and other things too. But it's shocking that after so much advances, such a basic thing, and so many people are suffering all across the world. So many people, how do I know? Because of the prevalence of somatic referred chest pain, abdominal pain, and pelvic pain I see in my practice or from the people around who are being referred here. It's very common, Mariana. It is not at all uncommon.
And I wanted to ask you, so just to give us an idea, like, do you have like not a percentage wise, or like how common it is from like the patients that you see that they have this referred pain?
I don't know. I don't want to commit any percentage, but it is pretty common in the sense almost 2 or 3, and I'm just talking chest pain and abdominal pain, 2 or 3 a week among all the patients I see. They are responding to the neck exercises or to the spine exercises, not just neck. It could be lumbar and thoracic too. And no, it is not at all. It is pretty common. And actually, when and this is such a common thing I see. And actually, it reminds me of some of the cases I've seen over the years, even before MDT. I remember I saw way back in 2004, 2005, I had a patient who had severe chest pain, severe chest pain. She goes to ER. She gets all the blood work done. She gets the CT chest done. She gets all the cardiac workup done, and no cause could be identified. And I remember seeing her on a follow-up, and I will say, oh, everything is normal. It is all because of anxiety. And now that I look back and I say, oh my gosh, I think I was missing that all along, and I didn't have any awareness. And that reminds me, and I would like to highlight this. This is what I have seen in my practice. Actually, so, I've got patient education prescribing exercise sheets, which I give to my patients when they leave. And I write a prescription, this many reps, this many times a day, so that they are getting a script just like a pill. Like, well, now everything is electronic, but in terms of the exercise, that's how they get the prescription. One thing I will share, and it's fascinating, like I would not have anticipated that when I was going through the McKenzie training, because part A starts with lumbar spine, and McKenzie is lumbar spine, initially and whatnot. The majority of because I've got the folders, the first folder which gets finished again and again is about the neck exercise, the retraction and retraction extension. And I cannot share with you how powerful that movement is. And actually, it is much more powerful in a woman. These are the people, women, far and large, gets much more neck exercise handouts than men. Have you ever thought about it? Why that could be the case?
No.
No? So I may share two studies by Ken Hansraj. He's a neurosurgeon in New York City, and he did two studies. One was he's the one where when text neck came out as to how the neck forward motion
Mm-hmm.
increases the pressure in the C spine and whatnot. But the reason I was bringing the woman was so then he did another study showing a woman and the size of the breast, putting the
Um,
pressure on the neck.
mm,
But I feel it is not that much the weight. Yes, in some women, it is the weight of the breast which influences the pressure. But I think more of it is our societal norm. As a young girl, when they are growing up, they're not walking like this. They are, and
mm-hmm.
that gets compounded. And over time, and I feel that's why, of course, women have more migraine. I'm not going there. I'm not brushing everyone with the same stroke. But I feel that's why they have more neck pain, shoulder pain, headache, and even the chest pain, meaning the referred pain,
Mm-hmm.
kind of a chest pain.
Yeah, it makes sense.
So women actually are much more afflicted with this because of those reasons,
Hmm.
I
Yeah,
think.
it makes sense. And like, I was curious to ask you if you start like identifying patterns. So like if you have like patients with like chest pain, abdominal pain, pelvic pain, do you start relating maybe they have pain in a specific position or when they are sitting, or like how do you relate? Do you have patterns that you start recognizing?
Mhm. So I'm glad you asked this question. I want to share another amazing discovery which I have seen over the years. So I have the privilege, and I'm just really, this would not have come about. So I'm a primary care physician. So the patients are stuck with me by and large, unless they fire me because I gave them exercise for the sinus exercise, which I have been for the sinuses, or I'm just making a joke out of it. But they are by and large, they are stuck with me for years. And fortunately, I love my practice. I've been in the same practice for 23 years. So you can imagine the same patient is coming again, again, again for different reasons, not for the same thing. And I'm very big in documentation in the problem list and documenting. Even when they get resolved, I don't remove it. It goes into my past medical history so I can scan it. So I'll share one of the two things, which is really very neat, which I'm not sure if a lot of MDT practitioners have noticed that. One is this: if you have a derangement of a spine, suppose if you have a derangement of a C spine, okay, those patients may have a derangement of C spine presenting as headache or presenting as shoulder pain at one moment in their time. But those same patients are much more likely to have thoracic and lumbar derangement. So they are the ones who are going to present with derangements in different parts of the spine over a period of time, over a span of time. So that helps me getting to the diagnosis much easier because I'm seeing in the chart. But one of the kicker is, and this will really shock you. Another beauty of this continuity of care is the same derangement. For example, the C spine. Let's talk about C spine, cervical spine derangement. The same derangement can present with different clinical presentations in the same individual. So, at one moment in time, the same cervical derangement caused left shoulder pain. One time it caused sinus issues. One time it caused elbow pain. One time it caused carpal tunnel. One time it will cause chest pain. So, when that happens, of course, I rule out heart and all that, but that gives me a lead advantage in nailing the diagnosis. Do you see what I'm saying? These people,
Yeah.
they will present with the same pattern again and again because by and large, people, the forces are the same. We live on this planet with gravity, and if their spine is not tolerating abnormal forces, yeah, they do exercises and correction for a while. Once they get fixed, they revert back to the same thing. So Those are the two things I want to highlight. So same derangement, different derangements in the same individual, and different clinical manifestations from the same derangement. And that's where a lot of actually humility and simplicity comes in, because many times patient will say, don't give me the same thing what you gave me for that, because it is very hard for them to embrace that oh my gosh, the same thing, the
Yeah.
same exercise,
I have a different symptom.
right? So it is. And we were talking about the medical labels or the quote unquote diagnosis. That's why those diagnoses are so up in the air. And in my problem list, Mariana, that's why I don't write a diagnosis. I know prior to MDT, I will write, I used to love making a diagnosis. I will call knee pain as osteoarthritis of the knee, or shoulder pain, whatever my mood is. I will write subacromial bursitis or rotator cuff tendonitis, or whatever my mood is for that particular moment in the day. And I will give a medical term to the problem. For the back pain, I will write, oh, it is spinal stenosis, oh, it's lumbar spondylosis or cervical spondylosis or whatnot. You will see there's none of that now. All it says is shoulder pain for this much duration and how it is behaving. That's it. It is shoulder pain or back pain, acute back pain, chronic back pain. That's it. Knee pain. I never write medical terminology, because knee pain could not be from the knee. It could be, as you know, it could be from the spine. Of course, it could be from the knee also, but then you do the corrective movement of the knee joint, the MDT movement of the knee joint, and that takes care of it.
Yes. And it's so interesting that like you are able to like see these patients for so long and
That's
see
how
their
it all
progress.
transpired. Yes, if I would not have, if the chart would not have screamed at me. I remember one time sharing a case where he had thigh pain, groin pain, knee pain, plantar fasciitis, and the last presentation was he was a runner and he couldn't run. So he had a hamstring. He thought he had torn his hamstring. But all that was the same lumbar derangement, which was causing different clinical manifestations over a span of 7-8 years. And if I didn't have that listed in my past medical history, I would not have connected the dots.
Yes. So interesting. Very, very cool. And so like how often do you see, because I imagine you can't see the patients that often to do follow-up. So I was just thinking about that.
Right. Very good question. So yeah, I cannot do the follow-ups that much. So many times I may see them one time, two times, and usually, but one of the advantages I have is if they are not getting better, they will call me.
Yeah.
Because they want imaging test to be done or they want to be referred. So I'll come to know they haven't. Of course, there's a whole process.
Find out.
I'll find out whether I goofed up or I messed up. I will come to know. Even if they fire me, I will come to know.
Yeah.
Because their follow-up appointment will not happen. And then if the nurse will call and they will say, oh, they have switched the doctors or whatnot. So either way, it is a very transparent system where I'm not living in a bubble or just thinking that, oh, everybody is responding or everything is hunky-dory. No, I get slapped right away when I fail. So, which is good. It keeps you grounded. And it keeps a good perspective on the way things are, because even if it is mechanical, as you know, some people will not do the movements, or if their brain truly believes that is not the cause, no matter how much you do, you're not going to overpower the brain, because as you know, all pain is produced in the brain.
Yeah.
And so it is not just MDT, it is also, I do want to mention the two modalities, which is totally, in my opinion, it feels like I've completed the circle in understanding the human body, so as to speak. I hope so. Is MDT, involving engaging mechanical to the practice of internal medicine, But a very important piece I want to mention is pain neuroscience. And the work which David Butler and Lorimer Mosley and um, Adrian Law here in US and other people have done is fascinating. And without actually, I feel the pain science actually helped me believe in MDT more, because as you know, there are so many varied responses we get when we are doing our assessment for follow-up. And then we try to put everything into that mechanical box, and it is
Yeah,
not.
it's not. Yeah.
So when it is not, you already know, okay, it doesn't have to be. No reason to get upset, or
Yeah.
no reason to try to put, they have shown us so many square peg in a round hole. You don't have to.
Yeah.
So pain neuroscience was another aspect, I will say, 5-6 years when I started embracing. And I don't know how many courses and certifications I've taken in that, but that really actually, it's a very fascinating journey about
Yeah.
pain science. That really actually helps you, I feel, makes you a better individual. When the patient now gets upset,
Mm-hmm.
nothing phases me. It doesn't
Mm-hmm.
phases me at all. Oh, they didn't respond, or
Mm-hmm.
nothing phases, because once you will understand, I don't know if you have taken spend time and energy into that, it
Yeah.
will totally change your perspective. You are always relaxed because you know, okay, it's fine. That is why this is not happening, and I cannot move forward
Yeah.
unless I change that neurotag or the neuroconcept
Mm-hmm.
which
Yeah.
this particular patient has. It is
Mm-hmm.
not their fault, but I remember earlier, it used to get frustrating. Oh, darn, the patient didn't do the exercise, she didn't get better, or if she got worse. Oh, I think I did everything right the first time. Second time, when she had a flare up, the same exercise made her worse, right?
Mm-hmm.
How many times have you seen that? And then
Yeah.
you wonder, man, what did I do wrong? No, you didn't do anything wrong. You rule out other causes. But if that is not the case, there's so much else which is the cause of that clinical presentation.
Yeah.
And so I feel just understanding changes the game when you are in the clinic. The ability to understand the issue, whether you can fix it or not, that's a separate issue.
Mm-hmm.
But just understanding what is going on, I think that is very rewarding. That helps you a lot. You don't get frustrated, you don't get agitated at all.
How powerful that you have all these tools to help all the patients, and you have the ability to do the diagnosis on the physician's perspective. Then you have a way to treat them mechanically, and have a way with the pain neuroscience education, super powerful to understand why they behave that way, why they are not fitting on the box.
Mhm.
Um, it's just so powerful. Yeah.
Right. I'll give you an example of that. Recently I had a acute back pain patient, and it was classic, very simple case. It was the story was very classic of extension principle, and I knew this patient will respond, but the patient was so insistent that he needs a medicine, and I knew he's so type A. So believe it or not, and I know this may not this may make some of the MDT people purist kind of a little bit unnerved. But I gave him a Kinolog shot. I gave him the McKenzie exercises. He comes back 3 or 4 days later, significantly better. He attributes the response to the Kinolog shot. It doesn't faze me. I'm not at all trying to argue. I said, okay, yes, that's fine, but just continue. Please do the exercises still. And then if you can do it twice a day or once a day on a regular basis, you'll be fine. But what I'm trying to share is, if suppose I didn't know pain education, for example,
Yeah.
and the patient I would have gotten upset. No, dummy, it is my exercises. It's the exercises what you have done, and you are totally poo-pooing all the work I did. You're giving benefit of doubt or credit to that shot
Yeah.
or whatnot. You know how many times that happens? It doesn't bother me at all. It doesn't bother me. Okay, that's fine. But the key is to engage them on the right track so that they don't fall off the track. That is more important.
Yes, very interesting. And I just was curious to ask you about the pelvic pain really quick and the abdominal pain. Do you see common directional preference on those cases?
That is also, yes, extension based.
Extension based.
So we are
Okay.
talking about pelvic, and Woody is the master,
Yeah.
Woody in Canada. But I'll share with you so much of incontinence
Hmm.
actually is spine related. It's not
Wow.
the Kegel, it's the same lumbar exercises which you will do. And one of the more powerful ones which I've been doing and which works actually much more implementable, if I may share, is slouch over correct. Just doing
Wow.
that is an easy one. People engage, and just doing that, stool incontinence. You will not believe in primary care. You see so much of those symptom presentation which they don't talk to anyone. They just suffer silently for years.
Yeah.
Anal itching, so
Yeah.
common. And they talk to me because I have a bonding with them. I know them for years. They will talk to me. But they will not seek out anywhere. They will not even their spouses don't know how much they are suffering, to be very honest. But they will share with me that I'm very embarrassed to share this, but this is what happens. And you know how powerful, how empowering it is when they are off their depends, and because they are no more afraid that a small stool might leak if they are
Mhm.
stepping up the stairs or whatnot. And
Yeah.
so on my YouTube channel, there is a case of rectal pain who suffered for 10 years, isolated rectal pain, for which he had all sorts of surgery, even the anal sphincter surgery. And Woody actually co-partnered in that case. I would encourage you to have a look at that. And that patient still follows me completely fine. And I think few years back when I first saw him, he was resigned to that he'll be in this pain for the rest of his life.
Yeah. How sad.
Yeah.
Yeah.
So a lot of pelvic issues actually,
Hmm.
and the sphincter issues. So Woody talks about erectile dysfunction. Woody talks about, um, and I have a case of urinary frequency also. A lot of frequency of urination actually is related to the spine. Now I know we are digressing into the internal organs, and the scientific people and the purist people may. I do not have explanation to that, but there is some influence. That's all I'll share.
Hmm. Yeah. And how about abdominal pain? How do they manifest the pain? What are like the symptoms? It's just like you know, just pain.
No, they can be having abdominal pain anywhere. The commonest I have seen is the right upper quadrant pain, to be very honest, and I feel that is part of the reason because we are majority right-handed. That's how I feel it. But they can be having pain wherever. Usually, it is intermittent. It is aching. It is vague. It usually doesn't have a clear-cut correlation with the meals, and you will find a mechanical history where they will say, oh, I feel it more when I'm sitting or when I'm relaxing. Oh, I don't notice the pain when I'm walking or when I'm running. And so these are some of the clues you get a mechanical history part of it. And I have a there are all sorts of abdominal pain. Now, it needs to be differentiated from abdominal pain from irritable bowel syndrome. But a lot of irritable bowel syndrome, abdominal pain also gets misdiagnosed, and it is actually a somatic referred pain. So,
Very interesting.
and that will actually, I will highlight this. And this is the very fascinating thing I've seen in my medical career, starting in India and all that stuff. How management of diabetes has completely transformed. How so many things have completely transformed. It's amazing. I owe it. I know a lot of people crib about pharmaceutical companies, but some of the discoveries they have done is just amazing. They have really statins or all these molecular drugs. So we can target the receptor, and we can be so specific that we can target, and it's just fascinating if you look at the science, biochemistry and the science which um, all these monoclonal antibodies targeting rheumatoid arthritis and whatnot. Same as with all these cardiac advancements we have seen in cardiology. We have very specific, um, the technology has helped so many lives, and along with all these drugs. However, Mariana, I want to share this. In terms of pain and in terms of musculoskeletal medicine, there is actually a technological paradox, if you may say. So the advancements have not led to the same level of relief. Part of the reason is because the answer doesn't lie in one receptor, right? It doesn't lie in one cell. Pain is complex. It is actually produced in the brain along with the tissue input, right? And so all that specificity and narrowness, which saw us see advancements in oncology, in cardiology, and respiratory world, in other areas, in musculoskeletal medicine, actually, it failed us big time. You know how the pathoanatomic diagnosis in the musculoskeletal medicine is so erroneous.
Mm-hmm.
So it's such an amazing thing when I reflect on it, that here we are on these different areas where medicine has made so much progress, but in terms of musculoskeletal medicine, actually you have to back off. And the answer is more simplicity. Of course, we talked about there is no appreciation of mechanical pain, even though the Nobel Prize was awarded to the scientists who discovered the mechanical sensors and the mechanical pain, the piezo sensors. But it is what it is. So you have to be able to juggle the minutia. At the same time, you should be able to juggle the wholeness or the simpleness in coming to the solution, and that is a challenge.
Yeah, the exercise is simple, but the rationale behind it together maybe not as simple.
Right.
Any other symptoms that are very different or unexpected that you see?
Or the swallowing issue is pretty neat because so many people again suffer from it. Clearing of throat, that is a good one. So a lot of people, again, you may not see all the people because they are in primary care, you see all these symptoms which doesn't get their due glamour and recognition, but they are annoying like heck or making life miserable of a particular patient. So I've got a case of an executive who was always clearing his throat while talking and all that stuff. So again, that clearing of throat could be from the postnasal drip. It could be from a side effect of some of the medicine like lisinopril, or it could be reflux, laryngopharyngeal reflux, like acid in the stomach causing irritation in the throat. It could be anxiety or a tic. You have just developed a habit that may be just your response to deal with the stress, right? Mm-hmm. But many times it is actually the neck. So it is the throat clearing, which is response to, again, the neck movements.
Yes, very interesting. Anything else before we transition?
No, thanks for your time, and thanks for giving your opportunity to speak on your podcast.
No, it's been great. Like, you're doing such an amazing job. Like, we have to scream to everybody, make everybody, know and see what you're doing, all your effort on trying to publish this and share with the medical community. And I'm sure your patients are very happy and having those testimonials on YouTube. I wanted to ask you, what is the name of your YouTube channel so our audience can go look it up and check all these interesting cases?
Yeah, it is not under my name. It is Mechanical Cause in Medicine.
Okay.
Yeah.
Okay. So you're going to put that on the show notes. And do you have any other resource of information that you recommend our audience or anything that you like in particular?
So, one thing I may share to the therapist out there, because so many people are suffering from chest pain and abdominal pain. And I think if they can make the analogy that the same buttock pain and thigh pain, which you see in the lumbar back, that is not a radicular pain, it is a somatic referred pain. And the same phenomena is happening on the trunk. And if the medical doctors are willing to engage with them after they have ruled out their medical causes, that is the number one
Number
thing.
one.
Yes, because chest pain is not just from the neck. There are four important organs there. There is heart, there is lungs, there are major vessels like pulmonary artery, aorta, and there is esophagus. And myriads of pathology or diseases in any of the four organs can cause chest pain. And many of them are actually life threatening, like aortic dissection or pulmonary embolism or acute myocardial infarction or esophageal rupture or pneumothorax, so as to speak. So it is not a easy thing when you are going to the trunk, because now you are going into the medical realm. But the medical doctor first needs to do all their due diligence, rule out all the medical causes. And once all that is ruled out and the patient is not getting better, I think they deserve a mechanical intervention. They do. And you will find out within a week or two. This is not, McKenzie is not like traditional physical therapy 3 times a week for 3 months. You know what I'm talking about. This is a diagnostic process. And within a week or two, you will come to know whether that is mechanical or not. And patient will see right away. It is not that hard. They will come to know, and that's it. And you help one individual, then you help two individuals, and then the pattern, these people need to be relieved from the suffering. A lot of them are being missed in the whole world, so as to speak. So
Yeah, and many of them are not gonna get referred to PTs or to
yeah,
get a.
because the medical doctors, they are not aware of it.
So we are missing all those patients.
Yes. But they can start, I may say, the MDT practitioners can reach out to their referring physicians. If it matters, they can share the paper. And if they have one patient who is not better, they can give it a try. And maybe that's how they'll get the engagement. I don't know.
Yeah, we're gonna share the paper as well on the show notes so people can go and check. And any advice for clinicians that are starting their careers?
Always keep learning. There is so much room to grow. If you are thinking you graduated or you got the degree, that is just the start. Actually, the patients will teach you, and the more you will read, the more you will apply, the more beautiful and easier it will get, actually. So you will enjoy more, because one thing you have to make sure is that you don't get burnt out, and you will have more connection with your patients, and you will enjoy what you're doing. Otherwise, people sometimes they get jaded and all that.
Yeah. And you understand the patients, as you mentioned, like now having the pain neuroscience education on top of your McKenzie training. Now you are equipped to understand the patients much better. So just understanding the condition makes all the difference.
Right.
Yeah. Dr. Vikas, thank you so much for your time and for coming share all your knowledge with us. It was so interesting, this conversation, and so many new things to just, makes us think a little bit more about the symptoms that you could see and the type of, conditions that we could help that sometimes we don't think about because they don't come to us, right? We're not going to see those type of patients. So it's just something so new and so interesting. And congratulations on your paper again. That is huge.
Thank you.
I hope you, don't give up, don't get frustrated, because you are the one opening, all these new ways and bringing all this to public awareness and doctors and, other healthcare providers. So we appreciate all your hard work, and, keep sharing with your patients on YouTube so we can see those different crazy cases.
No,
and
hopefully you will see more papers coming out now. I
Yay,
think,
yes.
yeah, getting published first time was very, very tough, but I think we have learned from our experiences.
Yeah.
So I hopefully that will help. So
Yes. Amazing. Amazing. Again, and if people want to find you or contact you, is that a way they can reach out or see your work?
you can share my email, Mariana. I'll be happy to. Yeah,
Okay, awesome. And your YouTube as well, right?
yeah.
You post there. Okay,
Please
awesome.
share that Nobel Prize paper too.
Okay.
That is very important because the piezo sensors, actually, the picture on that paper, it clearly shows that it is showing a force applying on the cell. And so for mechanical pain, you need a corrective force. There's no pill.
Yeah.
That's the bottom line. It is a directional preference force, what we call it, a corrective force, not just any force, not
Yeah.
just any exercise. It's a directional, it's a specific exercise, just like a specific pill. So
Awesome. Okay, will do. Again, thank you so much.
no, thank you, Maria.
We appreciate you.